I would like to introduce Dr. Russell Gelfman, who is the medical director of the work rehabilitation at the Mayo Clinic. Dr. Gelfman has been treating individuals with temporary and permanent disabilities for more than 26 years and is well known to many QRCs. Today, Dr. Gelfman will provide a perspective on medical care options for an injured worker with chronic low back pain through a case example. Additionally, Dr. Gelfman will describe how clinician, insurance, legal, and client attitudes and beliefs affect the medical treatments and outcomes of chronic low back pain. And now, Dr. Gelfman.
Thank you, and good morning to everyone. Hopefully all of you can hear this. And as you heard, this talk was put together with an idea of what does this look like from a patient perspective in terms of going through the system. So not so much as to what we do in the work rehab center, but kind of what patients are dealing with as they go through the system. So it has a lot to do with perspectives and beliefs and how that affects the return to work process. As a disclosure, other than my role as medical director of work rehabilitation, I have no financial relationships, and we're not going to discuss anything that's off-label. So again, the learning objectives is you should be able to gain a perspective on medical care options for an injured worker with chronic low back pain. We're going to do this through an interesting case example. And we're going to describe how the clinician, insurance, legal, and client attitudes and beliefs affect the medical treatment and outcomes. And in this case, it'll be chronic low back pain. Just as a little bit of a biography again, I have very varied experiences. I've provided care for injured workers on site. I've done this through an occupational health clinic and now through my work at an academic center. And so it spans the range from acute injuries through tertiary care, both for spine problems and for other work-related injuries. I've written papers, a book chapter, and also I've been a reviewer for medical guidelines for national organizations. So I've seen the acute conditions. I kind of broke those down into musculoskeletal treatments that are often done acutely, such as you'll go into the physician office and get a pill. You might get some time off work, or you might see your chiropractor and get some care. A lot of this doesn't involve intensive physical therapy, and a lot of times we could just wait it through, and many people return to work that way. So we're talking about the exceptions that don't return to work readily. And what that is, it leads to the chronic conditions. So in this, we have similar options, although oftentimes we can also consider surgery in addition to pills or injections, and physical therapies vary with modalities and types of exercise. Again, this is about perspectives. We're not going to talk about the person that you might deal with that's having a bad day or that you might be irritated with. It's more how this affects the medical care in terms of the way the system is put together. So we're going to talk a little bit about the role of technology and culture. So those are important themes as we work our way through this. We're going to look at the different outcomes, the fact that individuals that experience a condition that's treated under workers' compensation typically does worse than through other insurance types of support for medical care. And we're also going to talk about different perspectives among providers. From an administrative standpoint, we'll talk a little bit about medical experts, treatment guidelines, and delays in care. And from a legal perspective, why clients consult with attorneys So I'm getting a busy signal on my, there we go. Why clients consult with attorneys and perceived or social injustice. This is what pain looks like for an injured worker. It's not just that something hurts, but it hurts in a background that affects family relationships, your relationships in terms of your occupation. There's often legal involvement and involvement through insurance type payment and other administrative issues, in addition to how you interact with the medical system. So in America, or in American culture, technology really drives a lot of what we think about when you see a physician and what your expectations are. So Americans believe in fighting disease aggressively. It's one of the unique aspects of our culture. So the physicians that care for you have a highly technical, no holds barred approach to treating disease. That leads to high expenses, of course, and it's indeed trying to attack the disease and eradicate it. So science and medicine, in order to accomplish this, has a reductionist approach, or we think of the human body as a machine. And a lot of what you'll see in terms of decisions has that aspect to it. So I have a broken part. I want it to be fixed. I want it to be like before it was broken. The hard part with pain is that leads to this idea that there's a single painful generator. In other words, what you're seeing on the MRI or what you're feeling is a broken part. And so there is a magic bullet or a fix for that. And we now know that pain is much more complex, and it's a very dynamic system. Things can hurt that don't show up on imaging, and some things we just can't do to get rid of pain. And so it involves some degree of adaptation. So with that, we're going to start out with our first case here. So we're going to talk about Steve. Steve is a test pilot. He's piloting an experimental lifting body aircraft when it crashes in 1967. And I want you to pay attention to the dates. They're in there for a purpose, not for the specific date, but for kind of where it shows up in time as we develop our technology and culture. All right, he loses both legs in this accident, his right arm, and is blinded in the left eye. Dr. Wells is his friend. He's also a specialist in the newly emerging field of bionics. And coincidentally, the Office of Scientific Intelligence, which is a government agency, is looking for ways to reduce agent casualties. So they're looking for some augmentation of human performance. And because of this, they offer to pay for an operation to rebuild Steve using bionics and creating a cyborg, part man and part machine. What do we know about this? The stuff that doesn't kind of going on behind the scenes. Once completing rehabilitation after getting these new parts, Steve has a post-offer medical evaluation prior to starting his job as a secret agent with OSI. And the occupational medicine provider notes that he has a history of PTSD and depression from the accident, but he's improved. He's adapting pretty well. He's not requiring any medications. He's not needing any more psychological input. And so he seems to be doing pretty well. He continues to have phantom limb pain, but he's been able to function relatively well with distraction and take some over-the-counter analgesics. So now he's going to re-enter the workforce. He's found to be fit for duty. They didn't find any loose bionic parts. And psychosocially, again, he's doing really well. So he then he starts his job, and he has several successful missions using his now superhuman abilities. Okay, his missions, which are occasionally fictionalized or chronicled on TV in the early 1970s. And some of you may remember this TV series. He then was joined by a co-star, Jamie Summers, and she was on through the early 90s. And culturally, major impacts. So Jamie became one of the 100 most popular names of the year in every state in 1976. All right. So for those of you that are too young to remember, that was the $6 Million Man series. And I use that kind of as an illustration just to have a starting point for. Well, of course, he's involved in many altercations in his job. He gets encounters with Bigfoot. He frequently jumps up to, down from, and over high buildings and other barriers. He develops an L5 disc bulge, followed by episodic low back pain. So as this becomes more bothersome, he finally retires from OSI due to the inability to continue to work at this high level of physical performance. But he really is not restricted otherwise. You know, he's just aging. He's now developed a chronic back condition, and he's really just needs to move on. So after his career at OSI, he takes a position as an agent with the Minnesota Bureau of Criminal Apprehension. And one day he's lifting a box of case files and develops a worsening of his L5 disc protrusion, followed by worsening low back pain, still not into his leg at this point, and he seeks medical treatment. Okay, so he tries several things. First, he tries some chiropractic, doesn't seem to get better. He tries some physical therapy, doesn't seem to improve. He tries ibuprofen, that state-of-the-art medication in 1974. That's not really helping him. He then tries Vicodin, another brand new medication in 1978. It works a little bit initially, but it starts to fade in terms of its ability to help him continue his work. He also tries injections, which are actually quite old. They become more popular with time, but he tries epidural injections, and there's really no benefit for him. So then he switches to another brand new medicine. Now we're in the 1990s, or which was in the 1990s, OxyContin, and that doesn't seem to be helping any more than the Vicodin was, although his doses are going up. And he's unable to even sit in a desk. I mean, he's actually getting worse here. And he's starting to get a little bit of leg pain, and at this point, he qualifies for QRC services. So we're going to kind of walk through some of the issues that Steve's going to deal with as he engages all of these things in the work comp system. So this is going to be his downward spiral from here. He's sent for an IME. I mean, really, he should be better. The imaging doesn't look that much different than it did in the old days. And so the IME comes back saying that he's back to his pre-existing self, really doesn't need any further treatment, and really doesn't need any new restrictions. You're attending the office visit with him. He's seeing his treating provider, and his pain is just off the scale. It's 12 out of 10. He's on high doses of OxyContin. His PHQ-9, which is a measure we use to measure level of depression, 20 is major depression. He says he wants to work, but he feels worthless until he's, quote, fixed. Not only that, but because he's not believed to have any restrictions or anything, he hasn't been paid for 3 months, and he's kind of nearing bankruptcy. He really doesn't have a lot of savings from his old government work. However, he has seen a surgeon, and he's offered a lumbar discectomy infusion to fix his problem. Of course, this is very expensive. You know, if we're going to pick decisions here, surgery and the money involved with that, more injections, very, very expensive. And of course, now we have dispute here, and we need to get an attorney involved. And they're going to really try pushing for the surgery in order to fix him. And then if he can't work after that, you know, with all the injuries he had throughout time, you know, maybe something like permanent total disability. So this is really a big spectrum. If you're an individual going through this, you have a physician who did an IME who said there's nothing wrong with you or nothing different than what you've had in the past. And you have a surgeon who says they want to do a major operation, and you have other input that maybe even permanent total disability, I mean, you can't even sit at a desk, is on the table as well. This is a dizzying array of options for an individual to decide about. And so he's going to go through this downward spiral. There's been studies published. This is a real interesting one where a physician, an occupational medicine physician in New York, looked at 50 of the injured workers he was treating that had these chronic problems. 2/3 of them had lost their health insurance. Many reported their treating physician didn't want to become involved in workers' compensation, even though they thought the injury was somehow work-related. There was significant financial stress, medical costs, reduced income, bankruptcy, borrowing money, starting to dip in your retirement funds for what existed. And so almost universally in the group he looked at, the diagnosis and the related issues were associated with depression, anxiety, loss of identity, and self-worth. So now Steve is indeed caught in the middle. You get to walk through this with him. And the big question here is, what would you do if you were Steve? Would you just continue to use opioids, maybe up your OxyContin, opt for injections? Certainly is a thought. Would you indeed get some help and push for this lumbar discectomy infusion? Would you give up on working? Maybe indeed try to do permanent total disability and SSDI? Or what about restorative options through physical rehabilitation or functional restoration? We're going to talk a little bit about therapies and how they vary and how that's changed over time. And therapy for chronic back pain dates back a long way. I mean, back pain's been with us forever. In the 1930s, there was this thing called squat exercises that were kind of advocated. There was a concept behind that if you reduce the curvature of your lower back, that the disc space narrowing wouldn't be as profound, and indeed your back would feel better. And that was that idea of having a degenerative disc causing your pain. Williams did the same thing with flexion exercises, and just the opposite thoughts, that if you reduced your lordosis or the curvature of your back, you'd relieve elements, posterior elements, we call the facet joints. And so this idea between the disc and the facets are causing some of this dates all the way back to where we only had exercises to offer. This is before all those medications I showed you, before all the surgical interventions that were done, etc. This is where you get your pelvic tilt exercises for those that are familiar with the therapists give out, and some of the other knee to chest and stretching exercises. There was also this idea of core muscles, wasn't called that quite then, but using your abdominal muscles to brace your lower back. You would do this in the standing position, and you would try to strengthen these abdominal muscles and try to hold them that way when you would lift, push, or carry. And then McKenzie came out, and again, thinking about disc-related problems or mechanical issues with your spine, really a lot of pushing for that in the 1980s. We think of those sometimes as extension bias because a lot of the comfort positions were an extension. Again, thinking of these issues that affect the disc. Then we also had this other approach. Outside of physical therapy, we add some education ergonomics, or what we call back schools. And those were popular for a short time in the 70s. And the idea was to say that, gosh, we still have pain despite therapies, but maybe we could make you more functional. And so instead of individual PT, there'd be group education about ergonomics and back care. That was the Swedish school. The Canadian schools had similar ideas. Again, they took about misconception about causes of back pain, talked about the natural history of chronic back pain and the treatment role for exercise or physical therapy. And California had a school as well. And they built in some other stuff with using an obstacle course, again, to have people objectively perform things functionally, combining that with some education and even some work activities or body mechanics. And then we also had a paradigm of multidisciplinary pain programs, which work for more than just back pain, but this idea that you can apply behavior modification for the problem of chronic pain. And that started to come out in the late 1960s. And then kind of bringing you back up into the 80s, we had functional restoration, which was geared toward chronic, disabling, occupational musculoskeletal disorders. So remember what we're talking about here, this idea of degenerative disc disease or facet type pain. So this is a picture of a spine to make sure everybody's on the same page. These are the vertebrae, these are the discs, these are the facet joints, these are the nerves, all right? And in this case, in your lower back, these nerves will go down into your leg, and if they're pinched or compressed, they'll cause typically a feeling like sciatica, depending on which levels. So you can get pressure on this from a disc itself. You can also get this from degenerative conditions which narrow the opening where the nerve comes through. And then you could get facet type pain itself as we get these aging changes. And again, this is just another view showing what this bulge looks like, or indeed you can actually extrude material through the disc. This is what we call the nucleus pulposus. This is the annulus fibrosus. This is a very tough structure, and the disc can come through. The annulus is innervated on the outside. There really isn't nerve endings in the center. So we also think about discogenic pain, facet pain, or nerve or radicular pain. So what biomedical advances came to address some of those issues? From a surgical perspective, this idea of degenerative disc disease was treated with a fusion by this physician in 1952. So again, fairly old for some of this. It was a bloody and kind of an unpleasant surgery. So the big advances came in the 1970s when we had microdiscectomies, and indeed then even started doing fusions through a trans-lumbar interbody fusion, which were much less bloody than this, and they were looking at this in the early 80s. So this technology is not very old. All right. We also had a boom in the ability to diagnose things non-invasively. So EMG machines became digital in the 1970s and early 80s. The first CT scan in the United States was put out in 1973, and MRIs became available in the 1980s. And then, of course, we already talked about the opioids, and you saw some of those dates, Vicodin in 1978 and OxyContin in 1996. So now all of a sudden, compared to what we used to have for treating this, we have a lot of technology now that's very machine-oriented. On the other hand, the evidence for how well this stuff worked really hasn't caught up quite yet to the technology. So this idea of evidence-based medicine, the fact that we should offer things that have a strong research base that shows that it works, really that concept didn't start until the late 1990s. And that's when the randomized control trial became a real highlight of what we thought was the best type of study to provide the least biased evidence for safety and efficacy of an intervention. So the idea that you could take something like a surgery and say, you're going to have surgery, you're going to have something else, and pick that, not let the person pick it, but somebody else pick that for you and see how the two things turn out. You could do this with pills, injections, or any other type of medical intervention. They've done a lot of this with medical decision making. So the randomized controlled trial evidence, more than half of what we tell people from a medical perspective has some evidence of that level of detail to make the recommendation. So very strong evidence. However, surgical decisions in general, only about a quarter of them have that strength of evidence. And when it comes to orthopedic conditions, it's even lower. Only about 20% of those have one low risk of bias randomized controlled trial showing that operative interventions are superior to the way we used to do it in the old days, all right, with therapy. This is a study that I like to highlight because it really gets into beliefs as we work through it. But I want to talk about this trial, which was a randomized trial. And they're looking at surgical versus non-operative treatment for lumbar disc herniation. Okay. What they did is they took 501 patients. It was multi-center, all very experienced surgeons. And what they did was an open discectomy versus non-operative treatment randomly. So you came in with a disc problem, you had some leg pain from it, we thought the disc was causing it. Okay, draw a card, you got the card, you get surgery, you get therapy, or whatever else it takes to make you feel better. They analyzed the results of this after doing it, and they looked at what they call primary and secondary outcomes. When you design a study, you power it to look at a primary outcome. In this case, it was their functional abilities using some standardized questionnaires. One was the Oswestry, which asked questions like, how much does your pain interfere? And you rank this on a scale. With the higher numbers, then when you add up, the more difficulties you're having, the more difficulties you have dressing, et cetera, gives you a higher number. They looked at two scales, the SF-36 and the Oswestry as the primary outcome. A lot of secondary outcomes, botheredness of sciatica, return to work, some of these other things. And interestingly enough, when they randomized people, when you didn't have a choice here, primary and secondary outcomes were mostly equivalent. except for sciatica. So if you have something sitting on the nerve that's causing your leg pain, surgery is a little more effective than therapy for that. All right. We won't go some of the downsides to it, but some of them suggest that the whole study favored surgery because in order to do this type of study, you have to look at everybody, how they were assigned. So the problem they had is that there was something we call crossover. And so that's that we pulled together all these people, you drew a card and we said, you're going to have surgery. And the person says, I don't think so. I was going to do this, but I think I'd rather have therapy, and just kind of decided for themselves. Or the opposite. You were given a card that says you have to have therapy. This is bothering me too much. Yeah, I changed my mind. I really want to have surgery. And so those were crossovers. And so that kind of dilutes the effects of the intervention, and that caused a lot of controversy with this. But it also is reflective of what you do in real life when you make your own decisions. And there's also a concern that there was no placebo, and we're not going to really talk about that. So what I really wanted to get into with this study is what were the beliefs or the expectations of the people who made some of these decisions. So in the observational cohort, and we say by observational, this is the group that's not randomized anymore. They ended up making their own decision. I'm going to have surgery or I'm going to go for therapy. And interestingly enough, of that group, more than 2/3 decided that they would rather have surgery than therapy. Very dominant. These people had certain characteristics. They tended to be younger. They had lower levels of education. They had higher unemployment or disability. They had higher pain levels. They were using more narcotics to control it. They had worse functional scores. They had a lot of back pain related disability, and things have been going on for a while. When we looked at high expectations, and again looked in this group, as you might expect from what I've already presented, almost 2/3 felt that surgery was going to cure their problem. When you looked at the people who ended up selecting therapy, about 16%, even though they picked therapy, felt that it was really going to be highly effective. I think if I go to therapy, I'm just going to do terrific. So even the people that elected to have a non-operative type course didn't have a high suspicion they were going to do it. They just didn't want to have a big operation. So the expectation of potential benefit from non-operative care was the strongest predictor of treatment preference. And so again, they didn't think the care was going to work very well non-operatively, so they picked surgery. But of those that picked non-surgical treatment, okay, the better outcomes in that group were people who had high expectations that it would work. So if you thought, gosh, therapy is really great, and you did therapy, indeed, it turned out to be pretty good for you. All right. So your belief in that intervention made a difference in the outcome. That is the point of this slide. So what did we learn from sport? Number one, real world outcomes, particularly because people had crossed over. We also know that informed patients can choose their treatment, so it's not wrong to pick physical therapy, or it's not necessarily wrong to pick surgery. However, if you do pick surgery, it's not a minor procedure. Surgeons were experienced and respected. These were very experienced and technically good surgeons. Nevertheless, 4% of the people they worked on needed a reoperation in 1 year. 4% experienced a dural tear during their operation. The dura is what covers the nerves that are in your spinal canal. And so when you get a tear, you actually leak fluid. It's one of the complications. 2% of their patients required a blood transfusion. They had lost so much blood. And about a quarter of them required had an estimated blood loss of 1.5 liters of blood. All right, so that gives you an idea of getting into the beliefs between these. And now we're going to carry that out to chronic low back pain. And we're going to look at what about fusing versus doing cognitive behavioral therapy in combination with exercise. This idea that you could do a little more than physical therapy. You can combine some of that back school or some of those behavior modification techniques with therapy and get a better outcome than you can with therapy alone, and compare that to a surgeon like a surgery like fusion. They had to combine 3 trials. They looked at kind of this in a combined sense in this article. It was multi-center again. It got up to 473 patients, and they'd had chronic low back pain for over a year. They looked again at outcome, again, the oswestry, that's a functional scale, visual analog, that's like your 0 to 10 pain scale, how often the pain was coming, whether or not they needed pain medicines and how often, their work status, their quality of life, their satisfaction with care, and the global treatment outcome. A lot of the things you would think are important. And again, these are all self-reported, so they're asking the patients, they're seeing what they're using. This is kind of a real-world outcome of these 3 studies, and they looked at it 11 years down the road. So long-term results from this, and they couldn't find a significant difference in the patient's self-related outcomes between having a spinal fusion and doing the exercise and learning to adapt. People felt about the same level of disability, same levels of pain on average, same levels of medication use, same levels of ability to work in the 2 groups, all right? And again, this wasn't a workers' compensation population, but it shows you that our interventions, these 2 interventions don't make a big difference even in work status. So the fact that you're going to pick a spinal fusion and expect you're going to go to work and be better compared to doing these other things is really not borne out by the literature. All right. Another one, a little smaller study looking at a cognitive intervention with exercise. And this was 64 patients, large age range, again, low back pain more than a year, and these degenerative discs, both at L4-5 and L5-S1. Lumbar fusion and postoperative physical therapy versus the cognitive intervention, which had a lecture to give understanding that ordinary activity would not harm the disc, a recommendation to use your back, and indeed go ahead and bend it. Don't really hold back. It was reinforced by 3 times daily, so fairly aggressive physical exercise for 3 weeks. What are the results at 1-year follow-up? Again, the oswestry, the functional scale, improved in the surgery group. It also improved in the other group, all right? Maybe a slight difference at the end, but when people self-related their success, how they felt they were doing, it turned out that the cognitive and the exercise intervention, people actually rated their success a little bit higher, even than surgery. Again, not clinically significant at that level, but there were improvements in back pain, use of analgesics, emotional distress, life satisfaction, and return to work, basically the same in these 2 groups. Fear avoidance beliefs and fingertip floor distance. So again, trying to get us an idea of functionally how people are doing. They were actually reduced more after non-operative treatment. And it's not because necessarily the unoperative treatment, the exercise was better. It's because people also need to be encouraged to do normal activities, to bend, twist, lift. Those are okay. Your risk of re-injury aren't any higher whether you pick surgery or not. So these people with that instruction actually did a little bit better. However, lower limb pain was reduced more after surgery. And remember, we talked about that in the last study with the sport trial. If there is something pushing on the nerve in this group, surgery is probably a little more effective for this. So a straight lumbar radiculopathy is a little bit better for relieving leg pain, but for back pain and chronic back pain, no difference between these interventions. However, again, the early complication rate in the surgical group for this was 18%. So surgery is not a benign intervention. All right. Why don't we talk about Steve's other options? What about these opioids? Is it good to continue with those? What is the evidence for that? So systematic reviews are another way to pull together the good evidence, some of the better studies, to the degree you can find them. This particular paper had 14 studies. They had some criteria for this, but basically all trials looked at short-term management. A high percentage of harms were identified across most studies. Opioids were not shown to be superior to other medications, only to placebo. Higher percentages of harms in the opioid arms for the management of subacute and chronic low back pain. And the majority of trials that demonstrated benefits, interestingly enough, also had conflicts of interest. A lot of these were funded by pharmaceutical companies, and that's its own controversy. So what about opioids when it comes to returning to work? Prescription of opioids for more than 7 days for workers with acute back injuries is a risk factor for long-term disability. So from an acute perspective, you really want to limit starting people on opioids. Once they become using, or if they are using it, chronic use is a predictor of less successful outcomes after a work-related injury. And higher dose levels are associated with progressively greater indemnity and medical costs for ongoing disability, or what we call delayed recovery. So just continuing down the road of being on opioids, there's actually evidence that shows that it's harmful. What about injections? Do we have good evidence for those? All right, so for lumbar disc herniation or radiculitis, or again, radiating leg pain, the effectiveness of these epidural injections for long-term improvement meets level 2 in this particular paper. There's a lot of debates going on. There's no significant difference, interestingly enough, no matter how you inject it, whether it's a caudal, interlaminar, or transforaminal. There's other studies that suggest that there might be some differences, and that's what leads to level 2. So when we say level 2 insurance are levels of evidence for a trial. Level 1 is the highest level of evidence, and that means you have large randomized controlled trial with clear-cut results, similar to what I presented for some of the surgical literature in the slides before this. Level 2 are small randomized trials, and the results are not quite as clear. And indeed, that's where we're in with injections. We really don't have high-level evidence. They've done it for just plain old axial pain, or what we think is discogenic pain, again, without facet arthropathy or herniation. And they still thought there was some evidence for improvement in some studies. But again, it's only level 2. Post-surgery lumbar things are level 2 with caudal epidurals. And even though there were 52 randomized controlled trials in this particular synthesis, there was really a paucity of high quality randomized trials, which really confounds it. So the answer is we don't know to a high level of evidence how effective injections are, but there's enough there that you'll frequently see physicians basically offering injections. Okay. Why do workers' compensation patients do worse? We're going to go back to the sport trial, as well as they combine this with some other groups here in these papers. And we're going to pull this together and say, what's different? Why do you do worse under workers' compensation? All right. And indeed, they have some of these issues that involve our treatment choices and other things. A low educational achievement. They tended to work longer hours. Fewer weeks worked in the last year, so more of this temporary work was in this group. Higher physical demand jobs, more of them involved in legal actions, and had less financial resources. So indeed, they let people come into these studies that had workers' comp. They were a small minority of the total patients, and they were different. They fundamentally differed from what we look at for medical evidence. So it's a unique group of individuals that are looking at some of these treatments. Again, their beliefs feel less able to work without surgery, and the utilization of opiates and antidepressants was 50% higher than non-work comp patients in these studies. So my question to everybody out there, you can think about this, is do you believe that lumbar discectomy infusion would be a good option for these patients? They're different once you're in workers' compensation. All right, now we're going to actually look at the outcomes based on large databases that have been done by states that collect this. So this particular study was over 1,000 subjects. This was in Ohio. They have a single payer type system. They underwent fusion for degenerative disc disease between the years 1993 and 2013, and they had at least 3 years of follow-up. And they just want to look at how it turned out. And they eliminated the high-risk people. So they excluded those who had had prior surgery and failed. They excluded those who are smokers. We know that that's a negative outcome predictor. And they included those with failed back syndrome, which is a term we use for they have back and leg pain despite having treatment and nothing appears to be pushing on nerves anymore. So those people weren't even included. They just kind of threw those out. They were looking at people that had first-time surgery, they were going to have a fusion for chronic back pain. And of that group, how many of them were able to still be at work 2 years after their fusion? And it was less than 1 in 4 were still able to work. Okay. What were the poor outcome predictors? So this is the percentage of return to work in individuals who had a prolonged time out of work. So let's say they were out of work for a year. Only 1 out of 10 were able to return to work after that. So it gets pretty low. The big one was the psychiatric history, things like depression and other illnesses like that. Only 2% of those people returned to work after their fusion when they had that as a comorbidity. Prolonged use of opioid analgesics, we've already talked about that, and 12% were able to return to work in that group. If you were a male, only 21% returned to work. And if you had legal representation, again, about 21% return to work. So not the strongest predictors of these. Again, behavioral and mental health issues, very strong predictors of return to work. And again,
Dr. Gelfman?
yes.
Dr. Gelfman?
Yes.
Dr. Gelfman?
Yes.
We had a question that came in, says, regarding receptors within the brain, which make certain users more prone to dependence and other issues. And if so, is there a means by which to predetermine so potential problems can be avoided?
And actually, that's a very good question. And maybe if we wait a little bit, and you remind me again, I have a slide coming down for what we call risk factors or flags. And so, yes, the pain centers in your brain, if I'm understanding the question correctly, are also tied to our limbic system, which is what affects our mood. And these two things will talk to one another, okay? It's not the only thing, but opioids also interact with those systems, so it's complex, and there's not like a test you can do. But we're gonna look at some flags of things that you can pick out that'll give you a little bit idea of who's higher risk for these problems, if that'll work for everyone. Okay? Kind of getting back to this slide here, again, in this group that had the fusion, it wasn't a fix for over 3/4 of the patients that were in this. And the ones that didn't return to work, again, chronic opioid dependence, now they had failed back surgery syndrome. So now they had chronic back and leg pain. They needed additional surgery, or even ones that didn't have problems going in now had a comorbidity. Again, getting a little back to what we were just talking about, and that's that if you have chronic pain, your risk of developing depression is also increased. So it's a two-way system. So not only the fact that you have a history of depression makes you more likely to develop chronic pain, but the opposite of that also occurs. So again, why do work-disabled patients have worse outcomes? We talk about the biopsychosocial model. We won't spend as much time on biology, but in general, if you have poor, in general, age, gender, these other comorbidities, poor general health can affect your outcome. The psychological is the big one. Depression, stress, pain perception, motivation, fear avoidance, catastrophizing. This idea of, my back's blown out, or if I go lift that, I'm going to blow out my back. Those kind of loaded expressions are high risks for not returning to work. And indeed, your expectations, whether you believe you're going to be able to return to work or if you're kind of doomed. And then of the social aspects, the things we don't think about, and the administrative effects, some of which we mentioned above, the legal aspects of this, the fact that some care gets delayed. People just sit and ruminate about this while they're waiting for approvals or waiting for reports to come through. We talked a little bit about educational attainment. We're going to talk about perceived injustice kind of briefly, and we already talked about cultural beliefs. And that indeed is a lot of the emphasis of the talk here. There's also higher costs associated with these factors. So they've known that people that do undergo surgery, these biopsychosocial variables that were in the last slide predict medical compensation and aggregate costs of lumbar discectomy and fusion and workers' compensation in general. And cost reduction programs might benefit from identifying these factors related to increased costs. So this is the idea of identifying or trying to identify this stuff. And this is the slide I was referring to. Again, I don't know that there's a test or an easy way to pick this up, but in general, we think of this as being different flags, okay? Red flags are serious pathology. Indeed, you have a fracture, or you indeed are causing severe compression to the nerves, or you have a tumor. Orange flags are just plain psychiatric symptoms, so clinical depression, personality disorders. These are all, of course, more severe pathology, and the psychological stuff, again, we've already addressed a little bit of those. And the reason, again, that we are going through this is really the slide I think is the take-home message. I really like this when you break it down for this perspective. And when you're seeing a client, you can see some of this stuff as well, and you'll know who's the high risk for not being able to return to work by using this. And we're talking a little bit about the flag system. This is just kind of a way to try to remember these things. I'm going to start back into the yellow flags, and we already talked a little bit about beliefs and appraisals and judgments. And so again, if you think your pain is unmanageable, uncontrollable, or likely to worsen, or you think you're not going to do well, this is going to delay your return to work. All right. And you could pick those statements up all the time, I'm doomed, or you're just going to send me back, this is not going to work, etc. Those are very high risk type of things. Again, emotional responses in general. And this means you don't have to have a mental illness. And it's separated out from real clinical depression to the fact that people their mood just drops, particularly when you're hurting all the time. So you don't necessarily have to diagnose somebody as having a mental disorder of some type, but just the worry, the fears, the anxiety, feeling down about this is a natural response to having something that doesn't feel better. And that's an important risk factor for the fact that it makes it harder to return to work. And again, these pain behaviors and how you cope with it. So if you're avoiding the activities, of course, and work's one of those activities, you're afraid work's going to re-injure you, you really don't want to go back. And particularly if you're over-relying passive treatments, so hot packs, cold packs, analgesics, you don't want anything else. I want massage. I get these requests all the time. Those are not bad interventions, but they're risk factors for delaying or making return to work more difficult, because getting a massage usually doesn't make you able to lift boxes or do other physical activities better. It just makes you feel better while you're getting the massage. So it's not a bad intervention. It's just that this is return to work screening, if you think about it that way. We have what we call the blue flags, and those are perceptions about the relationship between work and health. So if you think your work is just too hard and it's going to hurt you, it's very hard to go back there for obvious reasons. And also if you believe that your workplace supervisor and the people you work with are not supportive. All right, other important things. And then, of course, the systemic things that just come along with this. So when you have legislation that restricts options for returning to work, that can interfere with getting back. If you have conflict with insurance staff or the injury claim, again, how the family and the healthcare providers interact with this, what they're trying to promise. People are desperate. And so if you offer them, I can basically chop off your ear and I'm sure you're going to feel better. I've had people that would probably take that option. They feel so bad. So you got to kind of watch a little bit what people are deciding, because they can actually make things worse as well. And of course, just the fact that heavy work is just hard to get back to, period. Whether you have an injury or not. So if you can't modify the duties, that's a high risk for not returning to that workplace. All right, so how do we intervene in that, and can we do it early? If you identify any of those things, getting to a more interdisciplinary approach, no matter what you decide for your other options, has some advantages. And this was a particular study looking at individuals with subacute and chronic nonspecific low back pain. Again, a systematic review looking at multiple studies, and clearly interdisciplinary approaches in patients at risk to develop persistent, that's nonspecific low back pain, is justified in both the subacute and chronic disease stages. So you don't want to send somebody to this that just hurts their back. They go through a few sessions of therapy. They have several sessions of chiropractic. They're getting better. They go back to work. They don't need an interventional, interdisciplinary approach. But if this is dragging on and they're missing work, you probably need to step up the game a little bit. All right. And psychosocial interventions might be more effective in subacute stages since a higher proportion of modifiable risk factors are identified. If you wait till somebody's bankrupt, getting divorced, has lost their job, getting them back into the workforce is really, really, really hard no matter what you do. So you need to do these kind of interventions somewhere in the middle. All right. They're not responding to the acute treatment, but they haven't lost everything in order to try to make this more successful. All right. We'll just briefly talk about administrative issues. Again, this is not to beat up on anything. These are just things that come along with the system. And so the big thing here is the IME needs to be a non-treating provider in order to get the type of opinions that you're looking for. But with not being a treating provider, they don't have to worry about these other issues depending upon whether you think they're work-related or not, which is the real thing that's a challenge. And that's this idea of causality. Okay, we understand that if you lift heavy, all right, and you get a disc herniation, that indeed we could tie that to work. But if you're somebody with a disc herniation that's also becoming depressed and stuff, where does that play a role in all of this? Did work cause that? I'm suggesting that that's a natural consequence of having these kind of pain that comes from that. There's differences of opinion, all right? And indeed, that goes along the same thing with pre-existing conditions. So just because that area was abnormal on prior imaging, does that mean that the fact that it looks the same means that there's nothing new going on? All right. They'll talk about reasonable and necessary care. Do you agree with the diagnosis? Do they recommend other tests or treatments? We'll get some of that back. Do you think they're at maximum medical improvement? Do you think this is only a temporary aggravation or it's permanent? Or you'll get the opinions that they should have healed. This should never have lasted this long. Again, based on a lot of assumptions. All right. What about treatment guidelines? So insurers also have, and indeed our state puts out guidelines for treatment. All right. And there's nothing inherently wrong with medical treatment guidelines. All right. It's nice to kind of know what the literature shows right now and what would make sense to do, but they are guidelines. All right. And all individuals don't fit in a guideline. All right. And insurance adjusters don't have clinical expertise and are not treating the individual person. So unfortunately, these guidelines become inflexible rules, which again limits what you can offer people when that happens. So there's good and bad to having guidelines, all right? And what about guidelines? They're based on previous research. So if you never allow a patient to go outside of guidelines, you're never going to be able to do a retrospective study that shows what happened to them, all right? Our knowledge is limited, and indeed, if you enforce these, it'll be limited for a long period of time. All right, they don't necessarily apply to an individual patient. Remember, guidelines are based on the cumulative, and you have people who did well and didn't do well in these studies. We're just looking at the best treatment, but not necessarily the only treatment when we develop guidelines. All right, they tend to focus on a single body part. They do save money, multiple studies showing that, but there's very little evidence so far published that they actually improve patient care. All right, and what about legal aspects? Our legal profession gets beat on all the time, but why do clients get attorneys? All right, what's going on that does that? And really, the idea is what we talk about: perceived and social injustice. The hardest thing to treat or to be involved in when you're a medical provider, taking care of patients under these circumstances. If you feel that somebody caused your injury or is causing you to not receive the care you think you need, that sense of injustice is very ingrained and very hard to override with anything. All right. So why do we get attorneys? All right. The claim's denied. So what other choice do you have? They didn't get contacted by their employer or insurer. They have unpaid bills. Again, this idea that the accident should have never happened. It's somehow the employer's fault. Overbearing or intrusive contact by the employer. There are some issues with advertising and some other things that have to do with the legal profession, but a lot of these are driven by the fact that they're stuck in a system. There's a lack of modified work. They get harassed after trying to go back to work. They're unhappy with the way things are going. They're losing their benefits, or indeed they're getting advice from all these different people, including medical providers. So we all have a little part in all of this. So what are the major concerns after all the things I've told you in the treatment of work-disabled patients? The big thing is the failure to address biopsychosocial factors, just overwhelming evidence.
Good morning, everyone. Looks like we're having some issues with Dr. Gelfman's presentation.
Okay, I think maybe we lost. Are we back on?
Good morning, Dr. Gelfman. We have one more minute for your presentation.
Okay, I'm going to try to speed
We
it up then
can
here.
partially hear you and we can see your slideshow.
All righty, I'm going to
Yes,
try
if
to
you
run
could
through
just wrap it
here.
up. Thank
We've
you.
had a few breaks. I'm going to try to do this, but the big thing is about beliefs and rehabilitative treatment, functional restoration focused on individual assessment of behavior change versus curing their problem. So what is CBT? Short-term, hands-on, goal-oriented, problem-solving. The goal is to change beliefs. In the setting of chronic pain, we address fear of activity, catastrophic thinking, and expectations. And what are the risk factors? This was a study published in Minnesota. I just throw this in. Again, medical things, as you can expect, the more injured you are, the more likely you are to not return to work, or these injuries that affect the head, neck, or back. And of course, the non-medical we talked about already. So really the summary, in a culture where we believe in the efficacy of medical technology to fix these conditions, beliefs about the appropriateness of doing these non-interventional things or functional restoration are underappreciated by everyone. And without neurologic involvement, the outcomes are similar and perhaps even more cost effective if we do CBT and exercise. And I'll finish here.
Dr. Gelfman, thank you for your outstanding presentation. Hopefully the recording we made of your presentation will be good, so others who missed the last part because of technical issues will be able to hear the rest of your presentation online. So thank you again. That was wonderful.
All right, thanks.